Today I'll be talking about the determinants of myocardial oxygen supply and demand. Firstly, I'll give a quick overview of the anatomy of the coronary blood supply. The coronary arteries are the first branches of the aorta and supply the myocardium and epicardium. The right and left coronary arteries arise from the corresponding aortic sinuses at the proximal part of the ascending aorta, just superior to the aortic valve, and pass around opposite sides of the pulmonary trunk. The right coronary artery arises from the right side of the aortic sinus of the ascending aorta. The right coronary artery will typically supply the right atrium, most of the right ventricle, the diaphragmatic surface of the left ventricle, part of the interventricular septum, the sinoatrial node in 60% of people, and the atrioventricular node in about 80% of people. The left coronary artery arises from the left aortic sinus of the ascending aorta. Typically, the left coronary artery will supply the left atrium, most of the left ventricle and part of the right ventricle, most of the interventricular septum, and the sinoatrial node in 40% of people. It's important to note that variations in branching patterns and distribution of the coronary arteries are common. We'll now examine the physiology of myocardial oxygen supply and demand, examining supply through flow and oxygen carrying capacity, and demand through heart rate, contractility, and ventricular wall tension. The regulation of coronary blood flow is a complex process which incorporates several different factors. These are metabolic control, autoregulation, extravascular compressive forces, diastole, humeral, and neural factors. The resting coronary blood flow in the human is about 70 mils per minute per 100 grams of heart tissue, or about 225 milliliters per minute, which is equal to about 4 to 5% of total cardiac output. During strenuous exercise, the heart in the young adult increases its cardiac output 4-fold to 7-fold, and it pumps blood against a higher than normal arterial pressure. Consequently, the work output of the heart under severe conditions may increase 6-fold to 9-fold. At the same time, the coronary blood flow increases 3-fold to 4-fold to supply the extra nutrients needed by the heart. When myocardial metabolism reaches a certain level, biochemical mediators may accumulate and cause vasodilation, increasing blood flow. These include adenosine, molecular oxygen, hydrogen ions, carbon dioxide, and potassium. Blood flow to the heart is auto-regulated, and two theories exist how it is stabilized. The myogenic factor theory proposes that the force of pressure on the vascular smooth muscle mediates vascular constriction, maintaining flow. Metabolic control theory states if concentration of a substance decreases due to pressure increase, vascular smooth muscles will constrict in response. Extravascular compressive forces are the mechanical force that act on the coronary vasculature, causing compression. These compressive forces include intrapericardial pressure, intramyocardial pressure, and intraventricular pressure, and approximately 30 to 50% of total coronary vascular resistance is attributed to these forces, decreasing the coronary supply. Coronary blood flow reaches its peak during diastole. Thus, the subendocardium only receives its blood flow during this phase. Increase in heart rate and prolonged ventricular systole would therefore affect the diastolic phase, impairing blood flow. Circulating factors may also affect coronary resistance, in turn affecting supply, such as angiotensin II, serotonin, thromboxane, prostacyclin, and bradykinin. These humoral factors bind to coronary endothelial cells to release substances causing either vasodilation or constriction of the coronary arteries. The autonomic innervation of the epicardial coronary arteries also has an effect on the supply to the myocardium, with the activation of different receptors causing either vasodilation or constriction. Oxygen carrying capacity of the coronary arteries is similar to all other organs in the systemic circulation and is determined by red blood cell concentration and oxygen saturation. Conditions affecting oxygen carrying capacity of the blood, such as anemia and thalassemia, can thus impair the oxygen supply to the myocardium. Now looking at myocardial oxygen demand. Oxidative phosphorylation is the exclusive mechanism for energy production under normal conditions in the heart. Three main factors influence myocardial oxygen demand. Heart rate is thought to be the most important determinant of myocardial oxygen consumption. Contractility is the rate of rise in intraventricular pressure during isovolumic contraction. This is influenced by the autonomic nervous system, heart rate, blood calcium level, and temperature. Systolic wall tension is also a major determinant in myocardial oxygen consumption, which is proportional to ventricular systolic pressure, ventricular radius, and inversely proportional to ventricular wall thickness. Preload and afterload are incorporated into the above parameters in that preload influences ventricular radius and afterload influences the magnitude of systolic pressure generation. Myocardial oxygen demand is an important factor in relation to supply, as a mismatch of the two factors could result in an inadequate supply to the myocardial tissue, risking ischemia and tissue damage. External sources on myocardial oxygen. Through their actions on heart load, some drugs have the capacity to influence the oxygen requirement of the myocardium. Alpha adrenergic agonists, for example, mimic the actions of adrenaline and noradrenaline in the heart, with the activation of alpha-1 stimulating phospholipase C and the activation of alpha-2 inhibiting adenylate cyclase. These alpha adrenergic agonists can be specifically alpha-1 or alpha-2, or non-specific receptor agonists. Beta blockers are competitive antagonists blocking receptor sites for adrenaline. Beta blockers, again, varying in specificity towards different receptors. Calcium channel blockers lower your blood pressure by preventing calcium from entering the cells of your heart and arteries. Calcium causes the heart and arteries to contract more strongly. By blocking calcium, calcium channel blockers allow blood vessels to relax and open. Nitrates are also commonly used to have a direct relaxant effect on vascular smooth muscles, dilating the coronary vessels and improving oxygen supply to the myocardium.